Right.
Okay, fine.
So I'm going to mute all of us and ensure that you are unable to mute so that we avoid background noises. Thank you very much. So in terms of today, I have already said welcome. I will just introduce you to the school quickly, and then we will then um, do our topic of the day around immune reconstitution inflammatory syndrome. And following that, hopefully we will have enough time for questions at the end. Just to say that I am the founder and director and the lead instructor at the Aqua Training School, which is part of the bigger group of organizations that aim to improve quality in healthcare. The school has a vision where we want everyone to achieve their full potential, and we do this by providing high quality education to everyone everywhere. We are an accredited school, and these are some of the reasons you would probably love working with us. These are some of the programs. I just want to encourage you, if you are not part of the NIMART training program, we do offer this HIV management guidelines course, as a free course. We have already actually close to 300 students who have already enrolled and completed the course. So we look forward to also hosting you on this particular program. If you want to contact us, just use the email support@aquatraining.com and we will be able to find us. So for today's topic, we are focusing specifically on IRIS, or what we call immune reconstitution inflammatory syndrome. And we are going to cover these topics. So it's a very basic case study, but then how common is this IRIS, and what is the pathogenesis? So what actually happens in the body in order for one to present with IRIS? And are all patients at risk, or we have patient populations that are significantly at a higher risk? And then we would also look into the burden on the health system, TB IRIS, and how it then presents. So this is a case of a 24-year-old male patient who is HIV positive with a CD4 count of 31, who lives with a brother who had been on TB treatment for 2 months, right? This patient was diagnosed with TB and actually completed the intensive phase of TB therapy. This was in August of 2009. And then he later converted to a sputum that was negative after the intensive phase. He had no cough, fevers, or night sweats. So during the 2 months after taking TB treatment, this patient was doing well. Then, because he was doing well, there was a decision to say, let us start him on ARVs. He was started on tenofovir, emtricitabine, and efavirenz same day. After 2 weeks of ARVs, so after taking this regimen for 2 weeks, he presented to the clinic with a persistent cough, a new fever, and also night sweats, right? His sputum was done at that point in time, which was negative. The chest x-ray, which was done a month later after completing the intensive phase, had an unchanged right lower lobe infiltrate and some lymph nodes. So the x-ray had not changed from what it was, when he started treatment. So that is very significant to note. But if we were to summarize this case, you are dealing with a patient who was doing well. The diagnosis is known. He has TB. He starts TB treatment for 2 months. He improves, no problems, no symptoms, no nothing. He's then started on ARVs, and 2 weeks after starting ARVs, it seems like he's starting to deteriorate, because now the cough is back, the fever is back, and now he's got also night sweats. When on examination again, he was hot, the body was hot, he had some difficulty in breathing, and he was actually coughing. And when they percussed the right lower lung, there was dullness on percussion with some rails, maybe telling us that there's something going on there, probably an infection. These were the bloods, and you can see the liver function tests were slightly abnormal, right? So what is this iris? So there is a case definition. It's an old case definition of what iris is. Remember, iris, we mean immune reconstitution inflammatory syndrome. So firstly, it happens in people who are infected with HIV, though the theory and the pathogenesis is something that is known also with other conditions. Patients who are HIV positive, the patient must be receiving effective heart. So this is quite important because this means that patients do not get iris unless if they are adherent on ART. So iris tends to affect patients who are good patients, who are adhering, right? So we are talking about an HIV positive patient who is taking ARVs and adhering, and we see this by an improving CD4 count, so the white cells are rising, and a decreasing viral load. So we know that the treatment is working. In other words, you cannot diagnose iris in a patient who has defaulted or who is failing treatment, because failing treatment is not iris. It means you have failed treatment, you are deteriorating, right? And in addition to being HIV infected and being on ARVs that work, they are presenting with symptoms suggestive of an inflammatory process. If you look at our case, he's got fever, right? He's got body pains, and so on. But also the clinical course, so the way the patient presents is not consistent with what we expected. So for our patient, if you look at the patient, is that he had TB, he was started on TB treatment. We expected him to improve and be better. Unfortunately, after starting ARVs, things became worse, right? So the clinical course is no longer as what we expected. We expected him to improve, but now he is actually deteriorating. So this is how you diagnose iris. In an HIV positive patient who is adherent and the treatment is working, and they are presenting with signs and symptoms of an inflammatory response. Generally, there's fever, right? Fever and body pains. And then also the way they present, remember, we expected him to continue to improve, but after starting ARVs, it seems like he was deteriorating. So that is very important. And this is basics about the pathogenesis. So you start someone on ARVs, their viral load becomes suppressed. As the viral load becomes suppressed, the immune system gets a chance to improve, and we see this by a rise in the CD4 count, right? When you have an improving immune system, there are benefits and there's also counter benefits, right? So the benefit is that when the CD4 counts are rising, you get the prevention of opportunistic infection. So the patient is becoming better, and we are happy, at that point in time. Just a few seconds, yes. And we are happy at that point in time. However, on the negative side is that as the immune system improves and we get this CD4, a rise in the CD4 cells, we have these inflammatory reactions, usually months or weeks to months after starting ARVs. So a rapidly improving immune system is good because we prevent opportunistic infections. But on the negative side, we don't like it because as the immune system improves, we get these chemicals that are released, and there's this exaggerated inflammatory reaction. And that is what we call immune reconstitution inflammatory syndrome. What is it? The immune system is reconstituting, so it is improving because we have given the patient R, the viral load is suppressing, the immune system is reconstituting. And as it reconstitutes and prevents opportunistic infections, we get this exaggerated inflammatory response, which we then need to manage or avoid, as needed. So that is quite important. So it is quite important and it's quite common. So the incidence, how often does it occur? In about a third of patients who start ARVs. So 25%, to a third of patients who start ARVs would actually get some form of ARVs, of iris. If you look into in South Africa, within the first 6 months, 25 patients for every 100 patient years, would actually get this disease. And you can see when it gets to TB iris specifically, so where patients are known to be having TB, like our case, and you start the patient on ARVs, right? Just above a third of patients who have TB who are started on ARVs will present with some form of exaggerated inflammatory symptoms, right? It is also not a new thing. We have seen iris in patients with leprosy before. Patients who have TB, especially the severe forms, and you start them on TB treatment and they get an exaggeration first before they improve, and then they later improve, So just note that it is not something which is rare. It is something that you can see also with other infections. So if you have patients and you are initiating your patients on ARVs, which patients should you pay attention to who are likely that after you start them on ARVs, they will then present with some form of exaggerated inflammatory response, right? So those with low CD4 counts, so that's number one. So if you are starting a patient who's got a CD4 count less than 200, they are at a higher risk of getting this exaggerated inflammatory response. Patients with high antigen load. So if you look at, for example, TB, someone who's got 1+ on their sputum versus someone who's got 3+, they are not the same, because the 3+1, it means they have a lot of TB in their lungs, and then they are at a higher risk of getting iris. Patients, look at this, better virologic response to heart. So it means iris tells us that the treatment is working, because iris does not occur in people who are defaulting and missing doses. It's very unfortunate that iris, it is generally experienced by patients who are adhering to treatment. So those with low CD4 counts, those with very bad infections, including extrapulmonary, disease, disseminated disease, if you're starting ARVs within 6 weeks of TB diagnosis, right? So it means in South Africa, we're going to have a lot of iris, because remember, our protocol says if someone has TB, you treat the TB for 2 weeks, then you start them on ARVs. And here we are saying patients who are started on ARVs within 6 weeks of their TB diagnosis, these patients are at a higher risk of getting iris, right? And then also, unfortunately, it affects also people who are Black. For one reason or the other, we should not make a lot of noise about it, but unfortunately, in terms of the genetic makeup, that's what it is, right? And then when does it happen, right? So we know that patients with low CD4 counts, those with very bad infections, extrapulmonary disseminated disease, are likely to have iris, but when? So we know that the majority of patients would present within 2 months of starting ARVs. So if you have a patient who's got a low CD4 count and you start them on ARVs today, right? You need to counsel the patient, empower them, give them science. You say, look, if your fever comes back, if you start to have night sweats, you need to come back, and you want to monitor them very closely, specifically the first 2 months after starting ARVs, so that you can then support them as needed when that time comes, right? So you can see that the majority actually of patients would come in the first month, right? Most of the cases happen in the first month after starting ARVs, and then the majority in the first 2 months, and then we have some cases that happen later on. So that's quite important, that in terms of how you manage your patients. If you start someone who is at a higher risk of iris, you need to monitor them closely for the first 2 to 3 months. Then after that, you can easily take them back to the regular schedule, right? So just remember also, note something to note that iris, there's two kinds basically. There's the infectious iris, which is from infectious diseases, and we've got the non-infectious iris, like for example, autoimmune disorders. So someone who is a known Graves or hyperthyroidism patient who is on treatment and they are stable, you start them on ARVs and they come back now, they've got hyperthyroidism, they're uncontrolled, as part of the iris. Malignancies, we have seen it with Kaposi sarcoma, which is a stage 4 disease. The patient comes in, they've got one small lesion on the skin, a dark, hyper-pigmented lesion on the skin. You decide to start them on ARVs, they come back in 2 weeks' time and they've got like 20, 50 skin lesions, all over their bodies. So that's quite common and really, like other inflammatory conditions. Imagine that you have a tattoo, that you did on your hand or wherever, when you were 6 and now you are a 40-year-old person, you start on ARVs, the tattoo reacts as if it's a new tattoo, that pain comes back. So there's all sorts of iris, but the key ones, which you need to pay attention to is the infectious iris. And we've got 2 types. We've got what we call unmasking, right? If you think of unmasking, it means there is a mask, something is not visible. You start ARVs unmask that disease which was not visible before, right? Then we've got paradoxical. Paradoxical, it means the opposite, right, of what was expected is now happening. So you've got a patient who has an infectious disease that is known, so they do have a diagnosis, and their own treatment, the patient is doing well, like our patient, it was 2 months on TB treatment, is doing well. And then you start the patient on ART, right? You start the patient on ART, suddenly that disease is back. So the opposite of what was expected is actually happening. So here we are talking about a patient who has a subclinical infection. So during history and the physical exam, we did not find anything. You start ARVs, after a week, they come back with coughing and night sweats, right? Here, we are talking about where we knew even before we start ARVs that the patient has a certain diagnosis like TB or Cryptococcus meningitis, which was treated at the hospital, and now the patient is back, no headaches, no nothing, he's on fluconazole and doing well. You decide to start the patient on ARVs. What happens? He comes after a week and say, hey, my headache is back, right? So that is paradoxical, right? So you must always be able to differentiate the two, because the management is totally different, because here we are unmasking a diagnosis that we didn't know about. So obviously here you want to investigate, confirm the diagnosis, and treat the patient. Here the diagnosis was known. We started ARVs when the patient was stable. Now the patient is like deteriorating of some sort. So what we need to do is assess few things. So number one, are you still taking your drugs? Why are you not doing well? Have you stopped your treatment? Or is this an adverse event? So the patient is not necessarily deteriorating, but it's because of whatever drugs we have started. They are not doing well on those drugs. Does the patient have a new infection? So they are sick, but it's not because of the previously known infection. This is due to another infection, So on paradoxical, you cannot just, treat it easily. We have to assess why is the patient deteriorating when the patient was stable before, right? I'm hoping you are listening, that I'm really hammering on the importance of differentiating between these 2 kinds of irises, if I was to call it like that, right? So as a graphic presentation, what you see here is that you've got a patient who is not on ARVs, right? They have some opportunistic infection, but it's preclinical. That means when you do your TB screening, for example, there are no TB signs. There's no history of anything, and then you do a physical exam, you find nothing, right? And if maybe there was no intervention, maybe the patient was going to have TB later in the year. But what happens is that a patient with a preclinical condition, as is the case, but here now we prescribe ARVs, right? After prescribing ARVs, that condition which was hidden now presents earlier than it would have been. So this is quite common with TB. A patient comes in, you do your TB screening, there's nothing. You do a physical exam, there's nothing. You start them on ART, they come back in 2 weeks' time with night sweats, fever, some loss of weight. You diagnose TB, then you need to treat the TB. So this is what we call unmasking. What has happened is that the condition was there, it was subclinical, ARVs unmasked it, right? So that now TB presents. So there was a mask, the condition was hidden, we gave ARVs, now we are able to see this condition. So how do you manage unmasking iris? Unmasking iris, how do you treat it? Well, you investigate at this level. When the patient now presents after you've started ARVs, you investigate, you do your sputums and smears, it comes back gene expert positive for TB, you treat for TB, and you continue your ARVs. You don't stop ARVs because ARVs tell us that iris actually tells us that the ARVs are working. Remember, who gets iris? It's patients who are taking ARVs where there is viral load suppression and the immune system is actually improving. So we know that iris is a good thing because it tells us that the ARVs are working. However, we want to manage it so that patients do not default or become unhappy, but importantly, they do not deteriorate over time, right? So here's the second one. Remember we said we are dealing with unmasking iris, remember, unmasking, where ARVs help us to see a condition that we couldn't see before. Then the second one is what we call paradoxical iris. So what is happening here is that, like it was the case with the case I presented when we started, the patient is a known TB patient. So he does have an opportunistic infection that we know about. The diagnosis has been made. He was started on TB treatment, right? He took the TB treatment for 2 months, right? And even the smears became negative at 2 months there, right? And he was now asymptomatic. If you take this blue color as symptoms, the symptoms disappeared. We said, oh, you're no longer asymptomatic, you're doing well. Let's start you on ARVs, right? We started him on ARVs, he was excited. After 2 weeks, he came back. He said, the symptoms are back. I've got night sweats, I am coughing, doctor, and my body is sore. Do you understand now? So what did the ARVs do, right? There was the ARVs are now working. Remember, the viral load is becoming suppressed. The immune system is improving. As it improves, there's this exaggerated inflammatory response against this TB, and it's making our patient to feel a bit sick. This is what we call paradoxical, because we started the patient when they were stable. They had a known clinical condition which was stable, but when we started ARVs, it seemed like that condition is becoming a bit worse. So that is paradoxical. So you must be able to differentiate between unmasking and paradoxical, because when ARVs unmask a condition, ours is to investigate and confirm that condition and treat it, right? When ARVs give us a paradoxical or a worsening of a known condition, we call it paradoxical iris. And your approach there is to do a number of things. Number one, are you still taking your TB treatment? Why are you deteriorating? Number two, are you taking your ARVs, right? Number three, maybe there's drug-drug interactions between ARVs and the TB treatment. So we need to check those drug-drug interactions. Number 3, maybe it's not TB, right? It's another condition that we had missed. So we need to then check and examine, the patient further and in detail. And sometimes it's the same TB, right, which was treated, but it is actually now a resistant TB. Because remember, any patient who deteriorates, who has TB and deteriorates whilst taking TB treatment, it's possible that the treatment is no longer working for TB and maybe it's a resistant TB. So just remember that, right? So for patients who are known to have a certain opportunistic infection, whether it's crypto, TB, herpes, and that condition worsens after starting ARVs, we call it paradoxical iris, right? If a patient is not known to have a condition, so when we started ARVs, we didn't have a diagnosis. The patient was okay. And we start ARVs, and after starting ARVs, the patient comes back maybe a week or 2 later with TB symptoms or headache that you think it's a crypto or whatever rash. This is what we call unmasking iris. The ARVs are showing us a disease that was there, and we need to diagnose it and treat it. So yes, continue to type your questions in the chat box. I will answer all questions immediately, after this topic, and then I'll go through your questions, and then you can also write them down. I'll give you a chance to raise your hands and comment. Now, the other thing is, don't think because I'm giving TB as an example that all irises are TB. Obviously, 98% of irises in South Africa are due to TB, but you can get iris from almost everything, right? From leprosy to pneumonia, candida, toxoplasmosis, cryptosporidea, herpes zoster, shingles, hepatitis B, molluscum contagiosum. So you can get iris from almost all possible infections, but the ones with the star, right, are the commonest ones. TB being the most common. So 98% of all patients who deteriorate a bit after starting ARVs in South Africa, most of them it's TB. But remember, it's not always TB, and you might need to refer them or even check them for other conditions depending on how they present, right? So consequences of iris is that, number 1, which is very important. Now, here I'm allaying your fears. Iris as a sub, we are not fearful of iris. Iris is a good thing. It tells us that the ARVs are working, and we know that it happens to people who are adherent. So we know that mortality is rare. Death from iris is rare. So don't be afraid of starting ARVs because you think people are going to die. No, you must start ARVs, and if they get iris, it means the ARVs are working, and we need to manage that iris. Patients might need to be hospitalized or with procedures. For example, if someone develops a lymph node, in the neck, and we need to drain it and so on. It does happen that after starting ARVs, someone comes with a lymph node, and it's a TB lymph node. It may impact on adherence, and this is important. That's why you must prepare patients before you start them on ARVs. If the C4 count is less than 200 and they are unstable, they are stable, and you start them on ARVs, make sure that the patient knows that there's a possibility that if I start you on ARVs in the next 2 weeks, you might feel a bit, as if you're deteriorating, or you might feel a bit sick. Please, when it happens, come and see me, so that when it happens, they don't stop ARVs and blame ARVs for making them feel sick. However, there's many research questions remain around this iris, and how it works. So as part of, as we head towards the end, of this topic, is to put it in the context of TB, just to say that paradoxical iris is quite common. So remember what I said, what is paradoxical? It means it's when iris happens in a patient who had a known diagnosis before they started ARVs. So the current TB they have after starting ARVs, it's becoming worse or it presents with a new clinical. So they had TB, it was stable, you start them on ARVs, they come back maybe with a lymph node. So they can get a return of fever, or if or even respiratory symptoms where they've got difficulty in breathing. So someone had respiratory challenges in terms of breathing. You started them on TB treatment, all those things disappeared. You start them on heart, now they present again with in distress or with breathing difficulties, right? A new enlarged lymph node, a worsening pulmonary infiltrate. So we knew that the X-ray was abnormal, but after starting ARVs, that abnormality is now growing, or they even start to have a new pleural effusion. If they had a small lesion in the brain, that lesion can actually grow to become big. This is the most worrisome one. So if someone has a lesion in the brain and they get an iris, you really need to watch them, because remember, the brain cannot expand beyond the capacity of the skull, so they are likely to cone, and that has very negative outcomes. So just remember that when we say paradoxical, we mean worsening of a known diagnosis that we had before we started patients on ARVs, right? So in terms of TB iris, a patient is diagnosed with TB. This is paradoxical iris, right? They are started on TB treatment. They are doing well. Like after 2 weeks of TB treatment, you start them on ARVs. 2 weeks after starting ARVs, they come back either with a lymph node or a pleural effusion, or even abscesses in the abdomen, or even a lesion in the brain, that's growing. So this is a very important slide, and it tells you that around 25% of patients who are on TB treatment, right, when you start them on ARVs, there will be some form of iris that they present. The majority is just mild fever and night sweats. Remember who is at risk: those with a low CD4 count, less than 200, those with TB beyond the lungs, those where we start ARVs very quickly. Remember, in the PMTCT guideline, there is a recommendation that women who develop TB, we can start ARVs and TB treatment at the same time in pregnancy, right? So here you can see that starting ARVs with TB treatment on the same day or even within a week increases the risk that patients would develop iris. So whenever you do it, you must educate the woman. You must also give her tips on the fact that when that happens, what must she do, especially coming back to you. She must not stop ARVs. And then if she's got danger signs, you might need to interrupt ARVs temporarily at that point in time, right? And I've already said this, that if it is paradoxical iris, remember, let's say it's TB. We knew that the patient had TB. We started him on treatment. We're expecting them to do well. If they're not doing well, it is not always ARVs, right? You have to assess all paradoxical irises to say, is this because of poor adherence, right? Maybe the patient has stopped TB treatment, or the patient is not taking ARVs, anyway. Or maybe it's the same TB, but now it has become resistant. So that's very important, to note. Maybe the drugs that we are giving for TB and the drugs that we are giving for ARVs are interacting. After you have excluded all of these issues, then you can say it's a pure paradoxical TB iris, where we need to reassure the patient and manage the inflammatory response. So this is quite important. As soon as you say paradoxical iris or paradoxical cryptococcus, you have to exclude whether your patient is adhering poorly, whether there's drug-drug interactions, and whether there's another infection, not necessarily the one that we had diagnosed before. So you need to go through, that list, as needed, right? So how do you manage TB iris? You manage it, it depends on how the patient presents. I mean, if they present with just fever, what do? You manage the fever. Remember, iris, immune, reconstitute, inflammatory. How do you manage inflammation? where you have to give anti-inflammatory drugs. Which ones? We've got steroidal and non-steroidal. So steroidal is your prednisone, for example, which you can give. Your non-steroidal are your Indocid, Voltaren, Brufen, So I tell you what, in my clinical practice, whenever I had a patient with iris and I gave them some Brufen, I tell you, they'll come back 2 days with a full check-in. Say, doctor, you're the best doctor in the world. Those drugs help me so much. Why? Because we understand that iris is an inflammatory, exaggerated inflammatory response, right? You manage it based on how the patient presents. You dampen that inflammatory response with your anti-inflammatory drugs. We always continue ARVs. We don't stop ARVs. We don't, unless if the patient is in trouble. But even that, it is quite rare, right? And here it is. If it is unmasking iris, so iris that happens on a patient where we didn't know the diagnosis before we started ARVs, what do? You investigate that condition and then you initiate appropriate treatment. If it is paradoxical iris, right, you continue both anti-TB treatment and ARVs, you reassure the patient, but you assess adherence, drug interactions, and to check if there's no other problem, right? And then where your patient is really not doing, they're not coping well, you then also consider adding steroids for the severe forms of iris. But like I said, your non-steroidals like your Brufen and Indocids, they really work. So as part of the treatment, I generally don't stop it. There's specific conditions under which we would stop ARVs, like patients who's got the iris from cryptococcal meningitis or from a TB tuberculoma in the brain, because there the risk is too high, and the pericarditis where TB affects the lining of the heart and the heart is unable to beat. Those are like the top 3, scenarios where you might consider stop. But generally for pulmonary TB and shingles and all those things, no. You continue ARVs, you reassure the patient, you manage the inflammation with your Brufens and Indocids, and then whatever condition that is, if it's shingles, you want to treat it with a cyclovir. If it's TB, you want to make sure that the patient is on anti-TB treatment. If it's cryptococcus, you want to make sure that the patient is on fluconazole and whatever other drugs that we need to use. So those are the principles. Just remember that giving steroids is not something that you should be doing all the time, because some conditions flourish when you give steroids, like MDR, TB, Kaposi sarcoma, the cancer, herpes, and so on. If you give patients prolonged steroids, these conditions can actually get worse, and that is the point. So yeah, so at this point, just to say, there is an algorithm that says a patient who has recently been started, who presents with an inflammatory disease, for you to diagnose iris, the first question is the patient on ART? If they present with fever before starting ARVs, it's not iris, it's not iris. There's probably some infection which needs to be diagnosed, right? If they present with a fever and you check, it's been weeks after starting ART, so that's possibly, iris. Do you have evidence that they are adherent and taking their treatment such that the viral load is being suppressed and the immune system is improving? If yes, it's probably, an iris. And there you need to treat the opportunistic infection. You continue your ARVs, and you might need to manage that inflammation with your non-steroidal anti-inflammatory drugs like Brufen, Indocid, Voltaren, and so on. And then you reassure, the patient. That's very important, right? If a patient comes in with fever, yes, they are on ART, but it seems like the viral load is up. This one is failing treatment, So failing treatment is not iris. Just remember that iris only happens on patients who are adherent, where their ARVs are actually working, the viral load is dropping and the CD4 count is going up. That's where, but if someone is failing treatment and they're developing crypto because of their failing treatment, it's not an iris. That is treatment failure, right? And iris rarely happens, when people have taken ARVs for more than 1 year. So what is iris? A patient who presents with some inflammatory, night sweats, fever, body pains. After starting ARVs recently, they are adherent, they are taking their ARVs, on a daily basis, and we believe that the treatment is working. That is iris. And how do you manage it? Whatever opportunistic infection, that is TB or shingles, you treat it. You reassure the patient. You continue ARVs and you manage the inflammation with your Brufen, Indosit, and so on. Just remember recommendations around TB. If patients have CD4 counts less than 50, right, cells, you want to start ARVs as soon as possible within 2 weeks after starting TB treatment. So you would start TB treatment, then start ARVs 2 weeks later. But remember, these patients are at risk of getting iris. So you would start ARVs, but you would monitor them very quickly. If the CD4 count is on the upper side, you have some time. You can even wait for up to a month before you start ARVs. So you treat TB for at least a month, and then you then take it from there. If they have drug-resistant TB, it's probably to wait for a month before you start ARVs, right? If we are talking about a pregnant woman with TB, here we are very urgent. You need to start ARVs as soon as possible. But remember to monitor them for this iris, because if you are starting early, iris is very high. Again, the timing is quite important. Remember, patients who have a CD4 count less than 200, you need to assess them very carefully and make sure that you start them as soon as possible. But remember, a CD4 count of less than 200 is a risk factor for iris. If it's TB or a stage 4 condition, you want to wait for 2 weeks before you start ARVs. You treat these conditions, for 2 weeks first. If it's TB meningitis or cryptococcal meningitis, really, you want to treat these two conditions for at least 6 weeks, then start ARVs, right? So who do you start same day? It's any person who is clinically, HIV positive patients who are clinically stable, right? So they don't have any of these conditions. Their CD4 count is a bit up, they are willing to start, they've got social support. Those are the patients that we fast track in terms of starting. So coming back now to discussing our case, it was a case of a 24-year-old male who is HIV positive with a CD4 count of 31, right? Now, this male patient lives with a brother. This brother has been on TB treatment for 12 months. This is very important. And then he has been, the patient was also diagnosed with TB and has completed the first 2 months of TB treatment. And during the assessment, the 2 months assessment, his sputum was negative, so he was doing well, no cough, no fever, no night sweats, no weight loss, so he was okay. A decision was taken to say, let's start him on ARVs, tenofovir, lamivudine, efavirenz, same day. After starting that, after 2 weeks, he comes back to the clinic. Says, yeah, sister, your medicine is making me sick. I was okay. I had no cough. I was doing well. Now I'm coughing. I've got the fever and I've got night sweats, And then you do an X-ray there. You realize that the X-ray has not improved, from the previous one that was done. So that is quite significant. And now he's got the body is sore, he's got a mild distress, and he's coughing, Sister Bam. So what is going on here? What is going on? So what is your plan, sister? What is your plan? It's your turn now to tell me what is your plan on this patient. So how will you manage, this patient, based on our discussion? How will you manage this patient? You can choose more than one answer so that we can discuss. Please try to choose what will you do for this patient. Come, let's vote, Sister Bami, just for 30 seconds. So will you investigate the symptoms? Will you reassure the patient? Will you manage whatever symptoms the patient has? Will you stop ARVs? Will you continue ARVs, right? So these are the principles of managing iris, right? 10 more seconds before I close your voting or your selection of your answers. 10 more seconds. Don't be shy, it's anonymous. I won't know which one did you select. All right, the time is up. So I'm going to end the voting and I'm going to show you the results so that we can discuss them. So investigate the symptoms. Yes, we have to investigate. This patient was doing okay for the first 2 months on TB treatment, and now suddenly, you know, he's having a new cough, a new fever. So what do? Yes, you investigate to say, what's going on? Why are you deteriorating? Have you stopped taking your TB treatment since we started ARVs? Are you taking your ARV drugs? You know, maybe there's a drug-drug interaction with some of the ARVs. Maybe he's getting a side effect, you know, which is causing him not to be well, or he's got another infection. Remember, he might have a TB, but now he has acquired COVID or some other pneumonia, you know, from other things, right? Or is the same TB, right? But it has changed. It is now a resistant TB. So all those things are quite common. So reassuring the patient, yes, always reassure the patient, educate, communicate with the patient. You can never go wrong if you do that. And you need to manage the symptoms, because if he's got fever, if he's got body pains, you want to give some analgesia. If he's got fever, you want to give something to calm the fever down, you know, depending on how they present. If it's a lymph node, you want to drain it. You know, if they've got a pleural effusion, you refer them to a hospital so that the pleural effusion can be drained. Stopping art, not yet. He's not acute. It doesn't seem like someone who will die, you know, like now. So we wouldn't stop. Generally, we don't stop, because remember, IRIS tells us that the treatment is working. So we don't want to stop the treatment. We want the treatment to continue to work, but we treat whatever, we investigate whatever the patient is presenting with, and we manage, you know, those symptoms. Continuing art, yes. We continue art all the time, except if it's something that affects the CNS, like a meningitis or TB of the heart, you know, where we know that the heart won't be able to beat properly. So TB pericarditis and all those. But generally, 99.9% of the time, patients present with fever, night sweats, and generally we continue from there, right? So here's then another question for you. So what do you think is the most likely diagnosis for this patient? What are your suspicions? We can never get it wrong, right? But what do you think? Does this patient have a recurrent infection? Is it MDR TB? Is it unmasking iris? Or are we having paradoxical iris? Yes. Sister Bami, Wazani. Few more seconds, 30 more seconds to allow you to select the best answer that you think is suitable from these 4. You may choose more than one option depending on your thinking. Right, 5 more seconds before I close the voting. 5, 4, 3, 2, 1 and go. I'm going to stop the voting and then we discuss, right? So there are the results. So some people say it's a recurrent or reinfection of TB. I mean, you know, he's got TB, he's on treatment. Why would he get reinfected? Look, it can be another infection. You know, it can be another infection. You know, it's not impossible. MDR TB is a great possibility. Why? Because there's quite a number of issues that can actually tell us that this patient might be having MDR. Number one is that he's staying with a brother there. Remember that brother who's taking TB treatment? What kinds of patients take TB treatment for 12 months? Is it the normal TB one? No. Probably the brother has MDR. So that tells us that maybe there's an MDR issue. Another thing is that, remember, even though he was treated for TB treatment for 2 months and he was okay, but the point is currently he's deteriorating. He's got another cough. How do you get cough after 2 months of TB treatment? Even if we think it's iris, right? So there's a chance that is happening. The other thing is, remember, the X-ray is not changing. The X-ray, that right lower lobe infiltrate is not changing. So why is it not changing? So the chances that he's got the MDR are actually a bit high, right? Now, here's where now I wanted you to show, your understanding of the topic. Is this patient having unmasking TB or paradoxical TB? Remember, unmasking means when we started ARVs, this patient didn't have TB, didn't have any condition. Now, this patient had a condition, which is TB, right? And was on treatment for TB. Therefore, we are not unmasking that TB. We knew that he had TB. Remember, unmasking is a patient where you have screened, taken history, examined the patient. You didn't find anything. You start ARVs, they come back in a week and they are coughing with night sweats and you think it's TB. That where you think ARVs unmasked, they allowed us to experience an infection that was not sort of there before we started ARVs, right? Now, paradoxical, where a diagnosis is known, like this case, we know that the patient has TB. We know the patient has TB. The patient was even on treatment. The patient was even doing well after 2 months of treatment. Then we started ARVs and he came back after 2 weeks with what? With some coughing and fever. So this patient here has what we call paradoxical TB in that context. And if I was to go back to my slides on paradoxical TB, there's a nice slide, this one. Paradoxical TB, it is important to rule what? Treatment failure, whether this is a drug-resistant TB or not, whether there is suboptimal drug concentration. Is the patient adherent? Is he taking the drugs? And if he's taking, are they being absorbed, right? Is this not a drug reaction? Is this not a drug-drug interaction? Maybe he's got another TB. So it can be, unmasking if you think that what is making the patient sick now, it is not that original TB. It is another condition. So the ARVs have unmasked another condition. So it's still possible, but then you need to find that condition. If we find a new diagnosis when we investigate, then we say it's unmasking. But if it is the same TB that he had when we started ARVs, then it can't be unmasking because we knew that he had that TB. Therefore, we would say that is a paradoxical iris. So to go back again to this slide here, patients on TB treatment, like our case, started on ART, paradoxical iris. Patient not on TB treatment, we didn't know that they have TB. You start on ARVs, they develop symptoms of TB. We call it unmasking iris. So that is a very important for you, to note, right? So in terms of our case, if I was to go back to that case, right? He had TB before we started ARV, so this is paradoxical iris. It's probably he's got MDR, we don't know. The only way we could say it's unmasking is if when we investigate this patient, we find that he's got COVID. Let's say, for example, we would have unmasked COVID with ARVs, right? So a new diagnosis after starting ARVs is unmasking. If it's the same diagnosis that he had before starting ARVs that is making him sick, which is the case here, then this is probably paradoxical iris, right? And just to repeat again, that don't forget that when we say paradoxical iris, I want to repeat that slide. It's very important. Paradoxical iris, you have to rule out these issues here because we are talking about someone who's deteriorating from a known condition. If it's unmasking, we investigate, right? We investigate that new condition, and then we start treatment as needed. So quite important, right? So this was the question I asked, which diagnosis. In terms of this case, you know, the patient actually had MDR TB, you know, because a gene expert was done and it came back to be resistant to rifampicin. And the recommendation was to start him on MDR TB treatment. But also from the history, there were issues, you know, being exposed to a brother who's taking TB treatment for 12 months. He's very immune compromised, our patient, you know, himself. He was doing well, but it seems like he deteriorated, but the X-ray also was not getting better. So, you know, so just why I want to emphasize that whenever you diagnose a patient with paradoxical iris, you need to exclude all those other things, issues of adherence, drug interactions, you know, adverse events, you know, and then if you have excluded those, then it is a pure paradoxical iris. We just reassure the patient, give some non-steroidal anti-inflammatory drugs. Usually they do better, you know, but don't just say iris. Iris is not a diagnosis, it's an iris from something. And that something is what you must find and manage all the time. If it is paradoxical, it means the diagnosis is known. If it is unmasking, it means you have to investigate through history taking, physical exam, then you know, manage your patient as needed, right? So take-home points is that iris is common. Now it's common, guys. I mean, in South Africa, in our clinics, it's very common, but we can manage it. So as Isabi, don't be afraid. It's not meant, I'm not meant to instill fear, but I'm meant to support you to ensure that you at least know what you are dealing with. It should not be a barrier to ARVs initiation. We should initiate, but identify high-risk patients, educate them, tell them what to do, and provide the necessary support. And by the way, I forgot to say that if you look at defaulters in the country, the majority default in the first 3 months of starting ARVs. And one of the reasons is because when they start ARVs, then they feel a bit ill and they blame the ARVs and they stop because we didn't prepare them, you know, for this iris. So ARV initiation in TB patients, remember, don't start same time, at least wait for 2 weeks. But remember, in pregnancy, you might need to fast track them, but do it with caution and ensure that they are okay. Thanking these mentors of mine. Dave Spencer is now retired. I know Prof. Graham is still in UCT. And remember, this is how you contact us. So yes, so I hope that this session was quite helpful. You know, you'll be able to help other health workers. We will share the video and I'm hoping you can watch it, you know, with your colleagues. But importantly, also help other family members who are taking ARVs and colleagues and friends. When they start ARVs, it's not easy. Some of them, they feel very sick. So our support can actually be quite helpful to them, especially if we are able to reassure them and help them to continue to take, you know,